Okay, can we have the slides for the panel? Now we have lots of questions, which I've just put in. So this is what I thought, that these are the difficulties that we practically face, and we'll just take them one by one, and any of us can take any of these. So maybe I'll ask Dr. Pandav to take the first one. You are in position, you think, but you just can't see the angle. What do you think would be the problem?
I think you, you have to look at the gonio interface basically. If you haven't put any viscoelastic between the properly, so it has to be nicely covered, and a good blob of visco is actually is very helpful. And then you have to position your microscope and yourself in position, but then you have to position the angle with the gonioscope also, so that that rotate the eye so that you can see. And the other thing that obstructs sometimes is when you enter the AC, if you're not clear corneal, there may be a little bit of vessel at the limbus where you have made the incision, and that kind of finds its way into the visco, and that kind of makes it hazy. So in that case, you just remove a gonioscope, wash it off, and then put viscoelastic again. But important thing is not to touch those limbal vessels, otherwise they bleed, and that keeps coming, under your gonioscope lens. So I think those are the usually things that we have.
Especially that limbal vessel thing, and once they keep coming, if your limbal vessel is at that angle, because gravity makes them keep going down, so that really is troublesome. Sometimes you don't know what to do. Faisal, any additions to when you can't see the angle?
Maybe sometimes a tendency to over-rotate the eye also.
Yes.
That's not
I was going to say that, that sometimes you rotate it too much, so then the angle has actually gone beneath the iris, and you keep rotating your microscope, but you just realize that it's the head which is tilted, especially in the ones with the sort of shallow or flatter corneas. If you just tilt it too much, it just hides behind the iris. So that's one thing that I've noticed. Srishti, any
also,
pointers?
if you are pressing over the cornea too much, that may also distort the angle.
Yeah.
So you have to gently keep it over the
Any Descemet's stria that we see is a problem. The other thing is we've started doing it in angle closure eyes. So usually that iris is bumpy. So it might be a problem. So sometimes I go in and I put a cohesive viscoelastic to flatten the iris, and that's the problem, that it's a bump. Any other pointers? Puri, you can join in with your Raya Madhuri.
Yeah, yes, ma'am. I have one question for the extreme, the superotemporal and the inferotemporal angles, where the rotation plays quite a bit role in the visibility.
During bang?
During bang, yeah. Okay. My question is for bang. So would a lens with the flange be helpful? Because what I have is a smooth, the normal Swan-Jacob lens, which we have. Because what happens is, at the extreme of the angles, the counter traction is kind of lost while you are
counter traction means?
As in, ma'am, the globe slips off. As much as you are doing it in the central part, which is quite clear, at the extreme angle, because maybe of the rotation and the lens, the visibility kind of hits off a bit.
You need to invest in a very good sister. And you have to insist, where is she today? Because they are the ones, they are better than my residents. Because they are there every time your residents will rotate. So they have to know exactly, if you're really wanting to do that, exactly how to hold the limbus at 180 degrees. I tell them pull it up and rotate.
Okay.
If they're going to pull it down and rotate, that's when it is going to tilt. Pull the eye up, and it has to be in that same plane, and they rotate while you're there. If you really want to treat them, that's the main thing. Some people use sutures for traction so that it's easier to rotate, and I don't remember who, but I've also seen them bridle the superior inferior rectus, so they say it's much easier to rotate.
Lift
so
it
each
in.
to their own.
Okay.
I wouldn't go so far, but you have to hold the limbus and rotate it.
Okay. Ma'am, would you recommend it holding it at just one clock hour, or both, like the 12 and 6, and then rotating it simultaneously?
Yes, two.
Both of them.
Both have to, and then rotate it. But it's also easier once you get the hang. If you have wheels under your chair, you just rotate it and keep going, and then rotate like that and keep going. So you just move. So have the eye in the same position and rotate with that. But now that GAT has come into my this thing, I've started doing less and less of partial. But partial. Bang with a phaco in a controlled patient is what I still do that. But for that, there is also evidence that it doesn't really matter. That's also true. I've heard lots of people say that whether you do about 120 degrees versus 180 degrees doesn't matter. So now maybe you don't need to rotate so much. That had come in from the pediatric goniotomy things where that was recognized. More angle is better. So that's when that rotation had come in. But maybe for adults, when you're doing it, maybe 100, 120 degrees of bang should be all right.
Thank you, ma'am.
I think that you are kind of stripping off 360 degrees, but that also increases the rate of complications. Hyphema is more in GAT and more severe as compared to
Just a bang?
yeah,
No,
just a bang.
necessarily depends. A bang, I'm okay with
Success
it.
is better with GAT, no? But
Much
yeah,
better with
IOP
GAT.
is much better.
Much
With the
better.
GAT.
Much better.
Yeah. I mean, there is evidence to say that the more you strip, the better it is. But I think if you look at some of the data, it suggests the minimum you need is about 30 degrees. So whether you want 30 degrees or 360 degrees, I think that's a
No,
question.
sir, I think there's evidence for 360 working more in GAT versus
Practically, it is.
Yeah,
at least we are
practic-
seeing, yeah, more result, better
it
results.
does. At least in children it works more. In adults, let me look at the evidence again. But there's no question that one goniotomy and two goniotomies would. So in adults also, sir, when it fails, they say do the other angle. So that's where these eye tracks have come in. So must be. Yeah, Purvi, sorry, one comment. Come to the mic.
360 degrees would be like more, give you more effect definitely. But kind of how much would be the difference? Like you have
Yeah.
180 degrees or 360 degrees. Would there be a really significant difference in terms of IOP or just some difference?
No, just one tip regarding this. I've just started recently doing goniotomy, mainly the bang. So what happens sometimes is you are all set, you started doing the goniotomy, but you don't realize and there is pressure at the side port, that entry point where you have
Okay.
just entered. So that gradually leads to leak of that
Yes.
visco.
Yeah.
And then slowly you start losing the sight of the angle. So that is something we
Yeah.
need to keep in mind, that at that time there should be no pressure over
Especially
the
posterior
point.
pressure.
Yes,
you should
yes.
hold it up
Yeah.
towards the
So I
good
actually
point. Yeah.
use a syringe filled with visco, and on
Yeah.
that I put a
Yeah.
26.
Yeah.
So the moment you feel that the AC is shallowing, you're losing
And then you have
visibility,
air.
you inject.
So then you
No,
have
no,
air.
Fortunately not.
And then when you inject, there's a and then it's all gone. Then you don't see the angle
Those
again.
small
Yeah.
things also we need
Yes,
to keep
yes.
in mind.
Well, little things. Right. Right.
Smudged
Yeah.
gonio lens also. Like sometimes the gonio, we are eating the gonio lens, no? It is smudged because of the
Yes.
previous use and it's not been washed well. That time also the visualization is very poor.
That's why I love
and
the Swan Jacob because it's autoclaved.
Yeah.
So there's no ETO residue, there's
Smudging
nothing
is
on
a
it. So
big thing because we don't identify exactly what is the problem.
Yeah.
Yeah, so many factors involved.
so that one time investment of 50,000 rupees is very good for a long time.
I think San Jacob gives you good visibility.
Yeah.
Only problem is a little heavier. So if you are not very good in your left hand, then you tend to press it a little more.
But the disposable lenses, for stability purpose, they are much better. They give better stability. Only thing is,
Hands-free thing.
yeah.
Multiple use, you can't use.
Right. So the minute you make the nick, it bleeds. I'll ask anybody to take this. What do you think? We've, I think, talked about this. The minute you make the nick in your angle, it bleeds. Yeah, we've gone deep. Usually that's the thing, that initially we've gone deep. You just have to nudge it a little bit. Whatever. But otherwise,
Put a little viscoelastic in that area, I think.
yeah, and then carry on.
The high viscosity.
Yeah,
and
go
then
ahead.
that will be contained and then you can keep working beyond that.
Ma'am, what do we do when we have lot of peripheral anterior synechiae and we are targeting the nasal angle and we are seeing, especially in the nasal angle, if we are seeing lot of peripheral anterior synechiae, what do we do in that?
So it's very,
Don't do mix.
but it's very easy to do a GSL, a goniosynicialisis, and it's very gentle to pull it down. In fact, the one which I showed you with the air was an angle closure after a goniosynicialisis. So we pulled it, and it's very easy to pull it down, except that when you pull it down, you want it to be clear, and that's when I said, Acha, inject, and that was that blob of air that you saw. But it's easy, and angle closure glaucoma, once we started doing it, we've realized that they work better. The bang works better somehow. And my thought processes, and then when you talk to your friends, I was talking to Monisha Nongipur yesterday, she has a grant on that. She wants to prove that angle closure glaucoma, I said, look at this. I've been saying this, and she's already got a grant from Singapore National Eye Center. So she is looking at the trabecular meshwork and the outflow in PACG and POAG with the same hypothesis that PACG is a trabecular meshwork problem, and it is possible that the outflow is lesser affected than in POAG. And therefore, when you treat the TM of PACG, the results of a bang or something, which we have anecdotally seen, you do PACG, you do that, you take it out and you do the phaco along with it. Of course, there's always that, is the phaco working or is it more? But now there is evidence to say that phaco MIGS works better than phaco alone and MIGS standalone alone. So I think if you combine a phaco MIGS, the IOP was albeit about 2.1 or 2.2 mm on evidence, but anyway, the phaco MIGS works better than phaco alone, and it also works better than MIGS alone. So if you combine the two, possibly in PACG you're getting a mix of both. So if you do a synucleitis, if you see Arvind's presentations, they have only chronic PACG, it seems, because they do just that. They use a cyclodialysis spatula to just pull down the synechiae, open up the trabecular meshwork and do the bang. I use the bang needle itself.
I was going to ask the next question, that which instrument is the best
I
for
use just that. Gently, but of course, just at the iris, pull that down and use the same needle. Then you don't go in and out. Makes the problem, I feel, is just going in and out business. Acha bhala, you can see the angle, then you've gone out, then you've gone in again, and it's all gone. So with that same. So that helps, sir. PACG.
I think there is now evidence to say that even these procedures work in PACG also. But as you said, it's mostly because they are doing the cataract surgery along with it.
Yeah.
And if you're not doing with cataract surgery, then whether they work or not, I think
I've actually done a
mark.
GAT in a PACG on 5 drugs and Dimox with a clear lens, standalone. And she's off everything except one PGA. So that we have evidence of that. Maybe I should
So what are
publish,
the chances
publish
of
that as a
to
case
see that?
report now.
What are the chances of reformation of synechiae?
Yeah, true. So if you do only a goniosynucleitis, they always reform. But I think maybe if you strip off the TM along with it, then possibly
I
that
think even then, because
sticking.
if the lens is in position and if
Yeah.
you have a shallow AC, I think
Yeah.
there would be,
It might.
Synechiae
after a few
formation.
months, we'll know what
Possible,
happens.
yeah.
Yeah.
But you are removing lens along
Then-
with it, then there's not
then
a
it's,
problem.
it's
then it's,
incomplete.
the problem is lesser. Right, Faisal, anything?
Okay.
Any tips? Okay. Right, this is another problem that we all used to face. AC is continuously shallowing, and I'll please ask all of you to interact and whatever your experiences with. This was initially continuously shallowing AC. Yeah, please. Doctor, please identify yourself. This is Ken Mishra.
Yeah, I am Dr. Pranab Kalita. I am the glaucoma consultant in Chandraprabha Eye Hospital, Jorhat, Assam.
Okay.
Okay. So what I feel is that this AC is continuous shallowing. So initially with the MVR knife, when you approach the angle, I think there is a you pressure on the posterior lip of the
Yes.
the 2.2
sclera, yeah.
incisions we make on the cornea, and it shallows. But then what I do, I go in. Then with the Swan Jacob in place, and I see the AC shallowing. Then what you do, my hand is steady, so I keep it there with the side. To the left hand, I inject again methyl cellulose.
Okay.
They see it becomes deep. Then I see that now since my MVR knife very
Snug.
that little distance away from the angle, with that amount of time I have in hand, I can nicely go and incise it.
Okay. Okay, fair enough.
Other thing is in PACG patients, it's better to give pre-op Dimax or mannitol to cut short the IOP spike during surgery, because in angle closure, it is the IO spikes are more peroperative.
So I think
maybe-
I'm a lazy surgeon, so I don't want to put in another another hole into the eye. But I tend to just take it out and put in visco. But initially, I thought it was very useful, as Purvi said, to have the needle on a visco syringe. So you don't have to go in and out, and you don't have to put in a second. So you do the bang or the goniotomy with a 25 gauge needle, rather than doing it with an MVR blade.
Okay.
So if you go in with on a needle on a syringe, and it starts shallowing, you just ask your assistant to push in a little bit of visco from
And there,
behind.
no, the problem, yes, madam,
Yeah.
of course, but the problem is that in MVN, I have the length of the needle is too good to approach. But in that 26
No,
needle, say
25
1 ml
gauge.
series,
25 gauge, 1.5 inch.
1.5 inch.
1.5
Okay.
inch, 25 gauge. The
Okay.
normal, the with your 2
Okay,
cc
okay, okay,
syringe,
okay,
jo
one,
needle aata hai,
one,
same,
oh, one,
that
okay,
same
okay,
thing.
okay, okay.
So 1.5 inch, 25. Of course, you have to reach the chota half inch 26 gauge. You can't reach
Yeah,
that.
yeah.
You can't do
Okay,
that.
okay,
That's
okay.
true.
And also you can make the incision smaller, not bigger, and use a high viscosity viscoelastic. I mean, Helon GB or NeoVisc, 1.8. I think then that shallowing doesn't happen.
Yeah, but the commonest problem is, of course, initially you tend to press down because you're only concentrating on that. And you also tend to press down with your lens. So that also will push it out in anything. Sometimes you do that or you press down. But yes, high viscosity, viscoelastic in the angle is the key. But of course, to coat the surface before that with, because initially the other thing that we tend to do, I've done that, scratch the cornea while going in. You're not sure. You're so this thing about looking at the angle that while going in, you don't realize that the cornea has also been scraped. So I always use HPMC first, soft shell, and then go in with cohesive viscoelastic in the angle. Faisal, would you do that while using visco?
No, I usually only the cohesive
Only
viscoelastic, and I think main reason is you are unknowingly pressing the
Posterior limb.
posterior. That is the most problem. You just
Plus pressure of the gonioscope.
yeah.
Yes, and the pressure on the gonioscope. Yeah. And of course, that makes the iris bulge up again, and then again your angle visualization is gone, and then you'll say, "Chodo yaar, just do the fico and let's come out." But wo chodo yaar nahi karna. Just go it. It'll roger your OT list because you won't realize that you spent 15-20 minutes in only seeing the angle. Surgery to abhi shuru nahi hui abhi, and then you think that you have, but then just hang on to it. Have a small OT list when you're starting with mixed surgery, and then when you see the results later, you'll really whatever. So the next I've seen is sometimes the trabecular meshwork pass is very scratchy. It's not smooth. Sir, have you encountered that somehow there's something wrong and you think there's
About in
the trabecular meshwork pass is not very smooth. It's a little, it's not like you'd want it.
No,
Any
I think-
phenotypes
I
that you've
think
noticed?
I think you have the right place, then
Usually it does.
Usually doesn't happen. I think.
Faisal, you've noticed anything, especially with the GAT, it's just not smooth enough. The pass is
Maybe the right.
I think juvenile open angle
Glaucomas
glaucoma
are-
sometimes you have that
that.
issues because there the Schlem's canal may not be completely developed in some cases. Uh, if the Schlem's canal is properly developed, then you don't have a problem. But some of these juvenile angle open angle glaucoma, I think they have an issue with the Schlem's canal, and there the success rate of cannulating 360 degrees may not
Is
always
lesser.
be successful. So there you can encounter a resistance.
Srishti, any phenotypes that you've noticed is not easy to.
Yeah, sometime while pushing the suture, there is obstruction and you are not clear whether you are going in the canal or there is a false passage formation. So in that condition, what to do?
Yeah, so then I just garrote it out. It never comes out of the canal, believe me. When you start just pulling it out from the other side, it's never that it'll come out of the canal. Somehow it always does garrote, how much ever it is, and you realize, "Arey, yahan tak it's almost till here," so you're almost done 220 or 200 degrees or whatever. So the phenotypes that I found this TM to be a little gritty is if you do it post aphakic. Somehow something happens to those eyes. The corneas are so thick, and I haven't found the reason. I've asked every cornea specialist I catch hold of, why is the cornea so thick in an aphakic and it's rigid? The IOP also when you take, be sure to take corneal thickness, and also in children, because aphakics the cornea becomes very thick and rigid, and maybe something happens to the sclera also. Removal of the lens might, I don't know why that happens. And Axenfeld is another juvenile, or like sir said, a developmental condition where something is wrong with that meshwork. Structurally, it's not as we this thing. So those are the few phenotypes where you feel it is not. I think it's fair not to force your way through.
Yeah.
If it's not smooth and it's not coming and you're not feeling it, it's better to say, okay, we'll call it a day today, and maybe he'll require a trab later, and tell the patient that. It's okay to eat humble pie once in a while and say, listen, we tried to do this, but we couldn't. it's okay, we couldn't. So we say that all the time. There's no
So if
harm.
there is-
Yeah,
If
yeah,
there is
Pooja.
some resistance and then you force it,
Yeah,
that means it has
it's
gone
worse.
somewhere.
Yeah.
I think last time we had it was the suture actually came to the anterior chamber. It crept on the angle over the
Yes.
trabecular meshwork.
Okay.
And I could see it coming.
Yeah.
I was very happy, okay, I've got it. And when I
Pulled it out.
started pulling, I thought, oh, it's in the anterior chamber
Yeah.
only. So it has come only halfway through and half was in the anterior chamber.
Yeah.
Yeah, once
Yeah,
I
yeah,
had
you were
an
saying
encounter where the tip was not properly made. It was not the
Yeah,
perfect umbrella.
okay.
It was half made.
Okay,
It was
yeah.
triangular shaped, and
Okay.
that's the time when it caused real problem. Like,
Okay.
yeah.
Yeah, it
Lot of
might also
difficulty in
go.
passing
It might also go
Yeah,
right
it
through.
went to the trabecular meshwork, like said, and it came
Yeah.
in the AC from the other side.
It
Yeah.
can come to, if it is sharp actually.
Yeah.
So it has to be
So,
rounded.
Yeah, it was
Has
not
to be
rounded well.
And the other problem I've noticed is in the bang, initially, sometimes we didn't bend it enough. So if it's not exactly 90 degrees, it's just one pokey thing. Then, you need it 90 so that it sits on the schlems and comes out. And sometimes it is too much. So if it's rounded and then you want to, manipulate that. So I think, Murli, you're here. Your comments on, we're just looking at problems. Any phenotypes or you've noticed when the trabecular meshwork pass is not smooth enough while doing a GAT or any procedure? What is your experience? Please identify yourself. I know who you are, but introduce you to everybody else.
Thank you, ma'am. I'm Murlidhar from I Foundation, Coimbatore. So, madam, in some patients, as you already mentioned, the developmental anomalies, Axenfeld Rieger's, the pass is not smooth. The other, this thing is in uveitic and in angle closure glaucomas also, sometimes the suture tends to come out at the site of a peripheral anterior synechiae.
Okay.
So,
All right.
it tends to come out at the site.
So when you're doing an angle closure, I asked Mohidin the same because he seems to show a lot of angle closure. So you've done a goniosynculitis, you've done a good goniotomy and it's come through.
Okay.
What I get scared of is, what about the PAS underneath where I haven't touched it? When you pass that suture through, is there a possibility of there being an iridodialysis or pulling out the synechiae? No,
it has
it
never,
doesn't
never
happen.
happened, madam.
You,
It has
the
never-
synechiae just get
The synechiae
cut.
just broken at
They
that,
just break
yeah.
and then they come. Okay.
But the problem is sometimes they reform again. So
Okay.
post-operatively, even if we give them intense steroids and pilocarpine, they reform again.
So we just
yeah,
talked
so that-
about
that- that's-
pilocarpine, Murli.
Yeah,
So
that's the happen.
my thought process now is pilocarpine is the problem for PAS. Because it's also pushing the lens iris diaphragm forward.
Forward, yeah.
So if what are your thoughts on possibly giving cycloplegic in the first week with the intensive steroid to push it back down?
If the anterior chamber is shallow and I had a couple of patients in which the anterior chamber was shallow or the suture had tracked into the supraciliary space.
Okay.
So in those patients, I do not give pilocarpine. Whenever there is extensive manipulation, like I have to do forward cannulation and then I have to do reverse cannulation to get it out. Or if there is an intense inflammation in the postoperative period or extensive bleeding, in those patients I avoid pilocarpine. I give intense steroids and I give cycloplegics for a period of time. But in the rest,
So it's very interesting that in Bascom Palmer, Peter Chang, he gives pilocarpine if there is extensive hyphema because he says that I want the surface of the iris to be as much as possible for the hyphema to drain. I mean, each to his own. I said I would never give pilocarpine if there is extensive
of-
hyphema. I would want it to go back. But he says if you give cycloplegic, then the iris also, I mean, there's dilatation also
Dilatation,
secondarily. And then there is no iris surface for the hyphema to absorb because
Absorb,
it's going to absorb through the iris.
But if
So I
the
said,
angle
"Wow,
is open,
very good."
Sir,
if your angle is open, the Schlems canal is open, the hyphaeum will go through that anyway.
Yeah, I did one
So you
case.
don't need
Yeah.
iris there to absorb the blood.
Just an interesting case. I did a phaco-bang in a patient. Post-operatively, he has a hyphema, and there was a blood in the retroanticular place in the back. That doesn't resolve even after 3-4 weeks, and we have to go again and
Yes.
do IA to remove that. Because the patient was constantly complaining of blurring vision, I just waited that it may resolve, but that didn't.
That is in
So
Was
it
it-
hemolyzed, but that remained there behind the lens, IOL,
Was it behind the lens?
Yeah.
Right, yeah.
Yeah, once
within
Yeah,
the back,
sometime
like CBDT.
I know I heard someone saying that it went into the Burgess space.
Burgess
actually,
space, yeah, if it goes
behind,
there,
behind the capsule. And then what do you do about that?
they have to do an anterior vitrectomy, I suppose. Sometimes with the pseudofakes, it just tracks through the zonules and it goes.
Actually, did in a couple of cases where there was a PCR. Where there was a PCR and in a few patients who had a dialysis also, limited dialysis. In those patients, it went into the vitreous. We gave vitamin C and, of course, involved the vitreoretina consultant also. It resolved almost inevitably.
From the vitreous hemorrhage
No, I
also.
think
But
it goes
if
in the
they're in
vitreous,
the-
that will get
Yeah.
That is
absorbed, like
that,
any
but-
vitreous hemorrhage, because
but
vitreous
if-
hemorrhage gets absorbed.
The Burgess space
eventually.
maybe.
But if it
because
is
the-
trapped
because
in
the-
the capsular bag,
In the
beyond
bag, it never
IOS,
goes.
it will
In
not
the
go.
bag, it never goes. Yeah.
And it's a very difficult time for you post-operatively if it's there's vitreous hemorrhage. Somebody who was 6'18" is now hand motions. So then it's really troublesome to wait. So I'm very wary of doing it now in pseudofix.
And this patient
AFix
was
also.
one night.
Yeah, my God. And AFix also, that's also a problem. Even in AFix, it tends to just trickle back and then so then it's a problem.
This is the one issue, the hemorrhage. This is the one issue actually, that this hemorrhage, this bleeding, which is preventing us from like going ahead
Yeah.
more and more with
Yes.
mix.
Yes. And of course, blood thinners. That's something I've learned the hard way. Whether or not what the evidence is, I don't know, but I have noticed if I stop the blood thinners 5 days prior, I'm safer than invariably it's a post hoc thing. You tell them, you're fine, yeah, I'm fine, and this, that. It's not enough. The history has to include, are you on aspirin? Especially hypertensives. Are you on aspirin is a direct question. Not that, yeah, I'm all right, because they think they're not on antihypertensives, but some medicine guys give them aspirin, low dose, that you be on aspirin, your BP is fine, everything is fine. So those I'm very careful of. And then the resistant bleeds, then I realized, yeah, I'm having aspirin. And I said, oh God, this is what happened. So be careful about blood thinners before.
But
prior to-
patient, mild glaucoma patient on one drug, it's better to try SLT before going for mix or like that.
So what is your experience? Is it true that somebody who does well on SLT is a likely candidate to do well with MIGS? I mean, that's a debate going on. There is some evidence to show that those who, once you do the SLT, then your MIGS is not likely to do so well because the trabecular meshwork itself, you've changed the character of it. So the only MIGS that will work is if you remove that trabecular meshwork. Whereas if you put in a device or an eye stent, it may not. But then some say that an SLT working means the outflow is good. And therefore, the MIGS is likely to do well. So any thoughts on what we should do?
I don't think there's any evidence
Correlation,
either
okay.
way there. It's just
But
anecdotal.
logically, the
But-
SLT doesn't cause scarring, so it
Yeah.
may not happen.
Yeah, so it should not make a
It
difference.
should not make a difference. And that
But,
thought
I
is...
think if your MIG is not working or SLT is not working, then the problem may be beyond the trabecular meshwork, is into the drainage channels or somewhere else. Because TM is not the only place where you have resistance.
Yeah, so that thought is all right, that if the SLT is not working, then maybe you're mixed. In that sense, you're doing an SLT first, may be some indicator for not or doing mix. So if the SLT hasn't worked at all, then maybe you tell them that it's less likely. I don't know. But that's another thought. How many of us would do SLT as first line for POAG? You do SLT in all your POAGs? Okay. Okay.
Yeah, in selective cases like patient who doesn't want surgery or allergic to drugs or in pregnancy, you want to do some extra.
I think
I think SLT
think
is-
we are not
yeah.
doing SLT as much.
As we
There's
should.
probably potential for doing more.
Yeah.
I think we are underutilizing
We're,
this.
yeah, because that's the general thing that otherwise SLT
Because
is...
it's very easy to prescribe a drop,
Yeah.
You just give, drop and you put it. And SLT you have to
Yeah.
you do
Go
a
to the
procedure.
machine.
Yeah, so you have to do a procedure.
Yes.
Here you are not doing a procedure.
Also the machine, the quality, because the previous one we had, that was very good, but this one is little, you have to bend forward and it, because of its design,
Yeah,
it's
so
difficult
the-
to do it. Yeah.
I mean, preferred practice guidelines are POAG, first line of treatment SLT. Everybody says that. De novo eyes, if you get. It is a good idea. I think the SLT madam has come. Ma'am, aajao. Discussion on SLT versus, do you do SLT in all your POAGs? Dr. Mayuri, of course, Dr. Mayuri will introduce herself, but she's one of the few SLT madams.
Actually, I started SLT in 2011
I know.
when everyone was opposing me when I started. That
Yeah.
it is
No,
going
I
to
was
be a
supporting you.
failure.
I was supporting you.
Thank you, sir, for that. And we also publish our data. 3 years follow-up. we found out that if you do it in juvenile open-angle glaucoma, it's not going to work. Then if it is a virgin eye, ocular hypertension, 1 or 2 drugs, those patients, they do well.
And high IOP?
Yes, of course. Higher the IOP, more is
Better.
the fall.
Yeah.
Okay, thank you, Sushmita.
And ma'am, since
I
this
remember one patient of a juvenile open angle glaucoma where it worked for some time at least. The reason was that the young patient, he had to go for the exams and his pressure was really fluctuating a lot. And he didn't want to surgery because he has exams. So I said, okay, I'll try SLT for you. May work, may not work. It worked for 3-4 months. His exams are over and then we did the surgery.
Yes, that is also one of the indications, sir.
Pregnancy
But
is one indication.
when we do the SLT, and particularly in the private practice, the price is, so many people, they do calculate. If you are doing it only for one drug, suppose patient is on PG, it is not worth in that case, because after 6 months, again, they are going to back on that.
Okay, so in your experience, how long does it last?
Yeah. But
No, how long does it last, ma'am? One SLT, in your experience, how long will it last? It does.
more, about 60% of the patient, it lasted more than 2 years.
Okay.
Because we were very selective in our.
Alright, okay.
Initially, we started with all, and then we realized that it's not going to work. And one patient, we end up in surgery.
Okay.
That lady was a young lady and already was on 4 drugs.
Okay.
So because of, and some patient where there is ocular toxicity because side effects of the medicine, there it is good idea to do SLT in those cases.
So one discussion was, ma'am, and what are your thoughts on that, that an SLT working, is that going to be a good indicator to do a MIGS later?
Maybe, yes.
Okay, because the outflow you think would be
Yes.
working.
But see, SLT, the mechanism is different. You are just
Yes.
cleaning up the meshwork, making them as good as the new one. So
But
that's
yeah,
the
I think
advantage.
what Sushmita is saying that, because if you, make the TM more permeable and IOP is low, that means the rest of the system is working.
working.
Yes,
Which
it
So
is
at least
good.
there's
So
no
maybe-
problem with the, Schlems
No.
Schlems
With the
canal or the
Schlems and the
drainage channels.
outflow.
Yes.
And there, if you are doing MIG procedure, it's more likely to work. Maybe.
Sir, to be very frank, my practice is a referred practice. I do more of a TRAB rather than MIGS because all those patients are
Yeah.
advanced cases of glaucoma. But in such cases, any MIGS should work. I stent or the GAT or the bang. I think it should work.
And the other problem with us not doing the SLT is again referred practice, cocktail
Yeah,
of drugs,
exactly.
advanced glaucomas. So, that's true. But like sir says, we are also lazy and we don't do SLT in our ocular hypertensions and the ones we also get to be lazy.
And one patient, today we have 6 years follow-up of that gentleman, 74-year-old. The daughter is ophthalmologist in USA.
Okay.
She came to India for the father. He was on maximum tolerated treatment, but not on the target, and never wanted to go for surgery.
Okay.
So in that case, we did SLT. He's doing fine even today.
Okay, nice.
So we have 5-year data on SLT in angle closure. I think the success rate, Fazil, who one was that?
Yeah, it's good actually. It's more than 70% is
60%, 70, up to 5 years. SLT in angle closure glaucoma.
So
Post
again the thought that angle closure is a TM problem and the outflow is good. so
That's
that's,
the-
what
that's the
Miggs is telling us.
hypothesis very well
Possibly the hypothesis is that. Last question, we have 5 minutes more and I'll take sir to do that because he's the only one amongst us who has patience rich enough for the eye stent. So that when the eye stent goes astray, what do we do?
I think sometimes it gets dislodged when you're doing it, and because your AC is filled with viscoelastic, usually high viscosity viscoelastic, so it doesn't kind of float away anywhere. It stays somewhere in the vicinity. So you can reload it in the AC also, or you can just grab it the nice force and bring it out and then reload
So
it.
does this happen with the inject and the W as well, where the flange is bigger? Now
I-
that
yeah,
the-
it
it
can-
does.
it is related to basically how it is embedded.
Okay.
Into the whether it's embedded in the right place into the temporal meshwork or not.
Okay.
And usually it happens when you are not looking at the angle and fast. So because you're looking at a slight angle,
Angle, yeah.
and when you inject it is not going straight, it's not going perpendicular, it's going a little angle.
Okay.
And then it's going to
Then
get dislodged.
But it's possible to
It's possible to reload it in the AC
AC
itself.
and then
But if you remove your viscoelastic and then if it gets dislodged during your cataract surgery, then probably you'll have problem. But it sort of never happens. Yeah.
Anybody has an experience of eye stents going astray or not going astray? Murli, any experience with the eye stent?
Madam, once it got implanted in the
It won't get recorded otherwise.
Once it got implanted in the trabecular, in the scleral spire actually. So
Oh.
I picked it out with the microforceps, got it out and reloaded and then
Reloaded
pushed.
outside.
Yeah,
So
reloaded.
it's possible to do
Yeah.
both.
Yeah,
You
it's possible
reloaded
to do.
outside as well as.
It's
Did you ever
possible,
try reloading within the SA?
No, madam,
you
I
haven't tried.
haven't. So it is possible.
I did try once, but sort of then you are manipulating in the anterior chamber and you don't want to do that.
Okay.
So my first attempt failed, so I just took it out and then reloaded
with the-
outside and then went
Okay,
inside.
with the same microforceps, the vitrectomy microforceps?
4 clicks you have you have 4 clicks with the current iStent W injector.
Okay.
So
4 by 3 injects, no? Or you have
two
4?
clicks you deploy 2, madam,
Okay.
and one actually went into the trabecular mesh.
Okay.
So when you have a mal deployment of one, what you do is you go to another site and deploy the second,
Okay.
and then you pull out this with a microforceps, reload it, and then go back and you shouldn't try to pull it out before you have deployed the
Then
second.
second one.
stent.
Okay. Fair enough.
Yeah, that's the recommendation.